my topic, suboptimal responders in control ovarian stimulation, are they overlooked? A good question. So I tried to think about it in three separate categories. Can we define this suboptimal response? What is the definition for suboptimal response? As you heard, what is poor response itself is debatable. So in order to define suboptimal response, we have to have good definitions of everything around it. The second is, are there any immunologic or molecular basis for such a category? And finally, what is the clinical relevance, if any? So the very question was asked last year by Polizos and Sankara in an opinion piece. And when you think about response to control ovarian stimulation, the easiest thing we can categorize is robust responders, actually. And then the poor responders, those who didn't respond as much as we would have liked to. And then the in-between where you say, oh, this is the one who didn't respond to robustly, and the one that did not respond poorly would be the normal responder. The question is there another small subcategory within what we thought of as normal response being suboptimal responders? For that, let's try to define, if I can make this move, try to define an ideal normal response. An ideal normal response should result in the best pregnancy. Ultimately, that's what the patient cares about, that's what we want as well. So the best pregnancy rate with the absence of ovarian hyperstimulation syndrome, obviously, because that is detrimental to her health. So from that, we move on to the robust response and define robust response as the one that results obviously in ovarian hyperstimulation syndrome, but also one that results in a lot of oocytes, but however results in a lower pregnancy rate. So that's the trickier part of the definition. Because if the person does not have ovarian hyperstimulation, does that become a robust response? It should, if it doesn't satisfy the first part of our definition, that it should result in the best pregnancy rate. So there are three papers that have looked at it in different ways. So Stewart in 2014 showed that if the number of oocytes retrieved were greater than 15, the pregnancy rate was not any better. So he didn't show that it was bad, but more is not more, or to paraphrase what was said earlier about enough is enough. So pregnancy rates, if they are not getting better with the increasing number of oocytes obtained, why should we even aim for that? So perhaps there is an upper limit of the norm at 15, and anything more than 15 may not necessarily be normal, could still be a robust response, even if the patient does not have ovarian hyperstimulation syndrome. The other way to look at it, Bart in 2007, showed that mild stimulation resulted in less aneuploidy in the embryos. So again saying that perhaps stimulating too many or stimulating to get too many eggs is not a good idea, and milder stimulation would result in better embryo quality, and therefore again laying the grounds for having a sort of a norm that lies within less than 15 oocytes. And RC also showed that more oocytes do not result in more blastocysts. So therefore, one can sort of try to set 15, maybe 20. Again, you can start looking at papers and you find different numbers thrown around. But for the sake of this particular argument, I am taking 15 as the upper limit of what can be considered as norm. So then let's move on to poor response. What constitutes poor response? That's even harder to define. The more number of papers you look at, the less convinced you are that anything is the correct number. But I would say that perhaps 3 and less is almost universally accepted as definitely poor response. Even the people who say 6 should be would agree that 3 definitely is. So looking at the lowest number, 3 or less number of oocytes retrieved as a poor response, then you have, again, this was the evidence for it comes from Kailasam and Polizos, then you have that in-between category of, by exclusion, between 3 and 15 oocytes being the normal response. If we look back on my original division of robust responders, poor responders, so anything in between has to be normal response. However, there is some evidence that 10 to 15 eggs may be the most optimal for pregnancy rates, and that comes from Stewart, Vandergast, and Werber. So if you then decide 10 to 15 is actually the best or optimal, looking back on our ideal definition for an ideal stimulation cycle, which would be best pregnancy rates. So using that definition, 10 to 15 eggs would be the normal response. That'll leave you within the normal response category, those with 4 to 9 oocytes having a suboptimal response. So it's sort of a roundabout way of trying to define this, but one has to define it, because if we don't define it, then we don't even have a category to talk about. So with that in mind, there is no convincing evidence, however, that improving the oocyte yield in these 4 to 9 oocyters improves the outcome. That is the problem with the argument. So we can make some elegant arguments, and certainly any one of you can come up to the podium and make a different elegant argument about a different number as well. But at the end of the day, definitions are there, and just as Dr. Dar was pointing out, that even the Bologna criteria has holes that patients don't fit into. So all these categorizations are ultimately artificial, things that we do for our own ease of defining and taking care of patients. So my second part of it, after defining between 10 and 15 is probably normal, and suboptimal is between 4 and 9 oocytes retrieved, is there any immunologic or molecular basis for making this assertion? Could there be some reason that patients don't, even though they expected to respond in a certain way, they don't respond as well? Possibly. So way back in 1990, Mayer published this paper where he looked at patients whose maximal estradiol concentration was only 300 picograms per ml with stimulation. And when he checked their antibodies against FSH, LH, and to the ovary, a substantial proportion of them actually had antibodies. And in contrast, none of the so-called normal responders had any antibodies. So it's not a surprise that one of the co-authors of the Mayer paper is Alvigi, and he has continued. In fact, he's the one who's got the next two publications. In 2009, he defined, or at least categorized, patients who had 5 or more oocytes, and then looked at the peak estradiol level in their cycles and divided them into 3 groups. Those that are 3,005, or not peak estradiol, I apologize. The amount of total amount of gonal F that was, or FSH that was needed. So patients who needed more than 3,500 units of FSH, those who needed 2,000 to 3,500 units, and those that required less than 2,000 units. Obviously, the ones that needed more than 3,500 units being poor responders. But what is interesting when you look into this paper is the peak estradiol level, even in those that require more than 3,500 units, was 1,500 picograms per ml. So looking at the paper that he published, or he was a co-author of almost 20 years prior, there is a marked difference from the 300 picograms that they had then versus 1,500 now. So why I'm highlighting is that even in authors who are publishing the same papers, the definition tends to vary from one paper to another. And this will be remarkable when you see his very next publication just 7 years later. But coming back to the question, he was looking at variance in beta LH in these patients. The theory being that these polymorphisms are responsible for a poor response in these patients as opposed to what was expected of them based on their ovarian reserve. And he found variance in 37% of the patients who required more than 3,500 units versus 6.7% in those who required 2,000 to 3,500 units. And of course, nobody in the less than 2,000 unit group had any variance in them. So next he looked, 7 years later, he published just this year at FSH receptor polymorphism. And he defined again, patients with more than 5 oocytes retrieved, but then he had only one category, those who had required more than 2,500 units of FSH. He didn't subcategorize as he did in the previous paper. Whether it's for convenience or he didn't have enough patients if he divided them, I do not know. But it is remarkable that there's no standard definition even within the same authorship. In any case, he found 58% of patients had this serine makeup that is indicative of a resistance to FSH versus 20% in the control population. So perhaps there is a molecular basis, theoretical argument perhaps. It is perhaps sound, but however, does it really clinically translate into a relevant category that we need to pay attention to and perhaps change or modify our protocols for? That's the million-dollar question. Now, Placido didn't define or use the word suboptimal, but in 2001, was already interested in this problem of patients who were normal gonadotropic but did not have the response that he desired. So 300 units FSH was the starting dose for all these patients. And he defined the suboptimal response as those on day 8 of stimulation had no follicles more than 10 millimeters in size, and the estradiol was low. And that day onwards, you would either switch them to 150 units of FSH plus menopur, which is adding LH, or keep them on FSH only. And the pregnancy rates was remarkably similar to those of the controls. So you can see when he added the HMG, 50% of patients were pregnant, which is similar to the 47% in the control, whereas the patients who were kept on FSH only had only 34% pregnancy rate. And this finding was independently correlated by Lisi in 2003, and of course we all add and supplement LH now. This paper by Beerwald was earlier quoted by Dr. Ho in his address as well about the theory of wave synchronization. He was talking about this paper in relation to fertility preservation, but the idea is the same, that there are waves of follicles that are coming through, and if you could stimulate at different times, you would be able to recruit all the follicles instead of only recruiting some of them. So their definition was patients having less than 5 follicles that are greater than 5 millimeters in size, or at less than or equal to 4 oocytes retrieved. And in those patients, they divided into 2 groups: stimulation starting cycle day 1 versus stimulation starting on cycle day 4. The theory is, of course, that cycle day 1 stimulation would actually gather more of the waves and get more follicular development. Disappointingly, however, pregnancy rate was only 10% in those who had the stimulation starting on cycle day 1, as opposed to 22% in those who were traditionally started on cycle day 4. I could not read this particular manuscript, but I did read only the abstract, and I have decided to include that only because, again, out of 137 patients, they divided them into those who were normal responders and those who were suboptimal. And out of the, which I do not know how they categorized, since I did not read the full manuscript, but 50 of them got recombinant LH and 35 had just increased FSH. And again, pregnancy rate was remarkably similar between the normal responders and those who got LH, but not as good when you look at the patients who only had an FSH increase. The ultimate bottom line in this is that we don't have good definitions, even for poor responders, as the plea from Cohen about all these definitions, which have absolutely no standardization across our literature. We do clinically, maybe there is some evidence that adding LH, which we all do already anyway, may increase the response. Now moving forward, there you go. To the question, suboptimal responders in control ovarian stimulation, are they overlooked? My answer would be perhaps. We do not know, is this even a category? Is this something that we should look into? I think research probably is the answer, but should we now clinically categorize these patients and start trying to do something different? We already do. We already add LH. That's what we are doing. So I don't know if that's something that needs to be addressed clinically in our day-to-day practice yet, but it's certainly worth looking into, perhaps with a view to changing our protocols even further and fine-tuning them. Thank you.